So this is the first one. So what is this? So where I have to see. Okay, it is a cranial ultrasound. Yeah, everyone is answering correctly. It is a cranial ultrasound. And what you are seeing, what are the views in this? What are the views? Yeah, the first one is a sagittal. This is a parasagittal view. Not exactly sagittal, it is a parasagittal view. And the second picture image B is showing the coronal view. Okay. So, and what is the grade of IVH? Yes, IVH grade 2. Okay. In the parasagittal view, we are seeing the bleeding, like we are seeing the intraventricular germinal matrix hemorrhage extending into the ventricles, and the ventricles are not dilated. Okay. And in the coronal section, we are seeing grade 2 IV, like intraventricular hemorrhage. So what are the two grading systems? What are the two grading systems? Yeah, Volpe papillae. Yes, you are correct. Okay. Okay, name one antenatal intervention to prevent this condition. Yeah, it is antenatal steroids. Okay. Excellent. So everyone is answering correctly. So it is a cranial ultrasound. Cranial ultrasound showing the parasagittal view and coronal views showing grade 2 IVH, and the two grades that we commonly use is papillae and Volpe grading system, and the antenatal steroids is the intervention to prevent this condition in the preterm infants. So coming to the next one. So what is this drug? So what does it contain? Yes, it is alprostadil. So it has prostaglandin E1. Okay, PGE1. Okay, when you will use this drug? In what condition you will use this drug? Yes, keeping PDA patent. For what? For duct dependent lesions, that is restricted pulmonary and decreased pulmonary flows and decreased systemic flow. So the condition where there is a decrease in the pulmonary flow and decreased systemic flow, like decreased pulmonary flow is pulmonary stenosis and pulmonary atresia, and systemic flow, coarctation of aorta, interruption of aorta. So we'll use this drug to keep the duct open. Okay. So what is the dose of this drug? Yes, it is 0.1 microgram per kg per minute. Yes, 0.05 to 0.1 microgram per kg per minute. It is given as an infusion. Yes, yes. And the side effects. Excellent. Side effects are apneas and most common side effects. Okay, so most common side effects are fever, flushing, apnea, hypotension. Yes, bradycardias. Okay. So what are the conditions that are aggravated by this medicine? When we should not use this medicine? Yes, absolutely. So it is obstructed TAPVC. So it is obstructed TAPVC and TGA with intact atrial septum or HLHS with intact atrial septum. Okay. Yeah. So now coming to the third OSCE. So this is a clinical picture. So what is this condition called? So it is Erb's palsy. Okay, Erb palsy. So how do you describe this position? There are four components in the Erb's palsy. There are four components to describe this position. Okay, it is shoulder. So shoulder abduction, internal rotation, elbow extension and pronation, and flexion of wrist. Okay, flexion of wrist and fingers. Yeah, abduction of the shoulder, internal rotation, elbow extension, pronation, wrist, and finger flexion. Okay. Yes. What are the risk factors? Site of lesion is C5, C6, C7. What are the risk factors? Any two risk factors? Yes, large baby delivered, macrosomia. Okay, shoulder dystocia, yes. Yes. Okay. What are the good prognostic factors? So the good prognostic factors is one of the early recovery, like within 2 to 4 weeks. So that happens in 86 to 90% of the infants, and unilateral involvement, and no paralysis or no involvement of diaphragm, and no Klumpke's palsy. Okay, unilateral involvement and recovery, early recovery are the good prognostic factors. Site of lesion is C5, C6, C7. Risk factors, as you mentioned, LGA, shoulder dystocia, breech presentation, difficult delivery, instrumental deliveries, and forceps deliveries. Okay. So coming to next OSCE, you have to comment on this X-ray, comment on these tubes and their ideal positions. So what is the ideal position for an ET tube? Yes, it is T2 to T4. Ideal position of ET tube should be at T2 to T4. Okay. And what are the other lines you are seeing? Yeah, UAC, UVC. Okay. Ideal position of UAC. So ideal position of UAC is T6 to T10. Okay. Yes, T6 to T10 is ideal position of the UAC, and UVC. Ideal position of UVC. UVC, okay, it is T9, like should be just above the diaphragm or 0.5 centimeters above the diaphragm. Okay, it should be just above the diaphragm or 0.5 centimeters above the diaphragm. So, and in this X-ray, there are no PICC lines, but what is the ideal position of a lower limb PICC line and an upper limb PICC line? Lower limb PICC line and upper limb PICC line. Upper limb PICC line should be above T4 and lower limb PICC line should be below T9. Okay. Yeah. Upper limb PICC line above T4, yes. And lower limb PICC line should be below T9. Okay. So we'll go to the next OSCE. So what is this graph called? Yeah, it is cardiotocograph. Okay, CTG. It is called CTG, cardiotocograph. So what is the baseline heart rate? And can you interpret the findings in this graph? Yes, there are decelerations. What type of decelerations? Whether they are early decelerations, late or variable decelerations? These are variable decelerations because it is the decelerations are variable with the uterine contractions and they are not coinciding with the uterine contractions and they are occurring very frequently. The variable decelerations are occurring very frequently. Okay, what are the causes of variable decelerations? What are the causes of variable decelerations? Yes, cord compression. Yeah. So cord compression, fetal hypoxemia, absolutely. Yes. Yes, cord compression, fetal hypoxemia, and meconium stain liquor. Okay. So these are the three most common causes for the variable decelerations. And what is your next plan of action? Next plan of management. If you see variable deceleration that are occurring very frequently with no beat to beat variability. Yes, it is delivery. If the mother is in early stages of labor, you will plan for emergency LSES. Okay. But if the mother is in already second stage of labor, you will hasten the delivery and you will plan for an instrumental delivery. Okay. The next plan of action is delivery. So, but it depends whether the mother is in second stage of labor or in the early labor. So we'll take for LSES or for an instrumental delivery. Okay. So that's all for today.
Yeah.
Everyone answered correctly. Yes, sir.
Yeah, carry on. Got some more thing to add?
Yes. Done, sir.
Okay.
Done, sir. Thank you.
Okay. Yeah. Yeah, it was wonderful for a nice pictorial OSCE I've done. Thank you. Thank you, Shravani. Thank you, Dr. Praveen, for sparing your valuable time and taking out your time and then spending almost 2 hours here for. And, thank you, Shravani, for.
Yes, sir. Thank you very much, sir. Thanks for the opportunity, sir.
Thank you.
Yeah. Good night.
Good night.
Yes.